Welcome back to ACCEL for March 2013. I'm Alfred Beauvais. Disc 3 begins with a discussion Anthony DeMaria had with Dr. Rachel Mackey, Assistant Professor of Epidemiology at the University of Pittsburgh in Pennsylvania, on HDL particle concentration is a more powerful risk predictor than total HDL cholesterol.
So welcome to ACCEL, Rachel. Can you tell us a little bit about the study that you performed?
Yes, we were fortunate enough to have the data from the multi-ethnic study of atherosclerosis, MESA. So that was over almost 6,000 men and women ages 45 to 84 years old, and they had no pre-existing cardiovascular disease. And we excluded people using lipid lowering at baseline. And we had measures of HDL cholesterol and HDL particles measured using NMR spectroscopy, and also LDL particles and LDL cholesterol. And that study is wonderful because we had not only about 7 years of follow-up, but we also had, for cardiovascular events, but we also had carotid IMT measured at baseline. And so when we compared HDL cholesterol and HDL particles in relationship to carotid atherosclerosis and then to cardiovascular events, they had similar associations with carotid IMT and with events when they were adjusted for smoking, hypertension, age, and race, ethnicity. But when we accounted for the underlying inverse associations of the LDL particles and LDL cholesterol, also for the relationship between HDL cholesterol and HDL particles, accounting for those other factors essentially adjusted away the association between HDL cholesterol and events in athero, but not HDL particles, which remained essentially unchanged by adjusting for those other factors.
So that's really interesting data, that HDL particle number correlate with carotid IMT, which of course is a surrogate, but also with events in MESA over 7 years. But HDL cholesterol didn't when you eliminated some of the other atherogenic lipoproteins. Why do you think this is?
The hypothesis, of course, is that it's becoming more and more clear that the cholesterol carried by the HDL particles is not necessarily a key functional player. And so it looks like since they carry something like 75, at least, other proteins that have biological functionality, that basically measuring the number of ships may be more important than measuring the cholesterol cargo that they're carrying. It may be related, their functionality may be more related to other cargo that they're carrying.
Of course, as you say, there's been a lot of attention paid to the functionality of HDL in an attempt to explain the paradox that low HDL seem in study after study after study to be associated with substantial risk of atherosclerotic events, but that raising HDL hasn't proved to be very effective to this point in time, and perhaps we've been looking at the wrong thing. Now, did you look at, say, for instance, apolipoprotein A to see if that was of value?
In MESA, currently, that was not available to us to adjust for in the analysis. The EPIC Norfolk study has looked at ApoA1 in relationship to events, and found that when it was adjusted for HDL cholesterol, I believe that it still maintained an inverse association with events, whereas HDL cholesterol adjusted for ApoA1, they also saw that it became positively related to events at high levels. So we also looked at that in our study, where we looked at very high HDL cholesterol, the 95th percentile or greater, so 80 milligrams per deciliter. And when we compared those people to those with 40 milligrams per deciliter or less, there was actually a significant positive hazard ratio. It was 2.59 when you adjust for LDLP, HDLP, and triglycerides. But when you look at the upper 95th percentile HDL particles, adjusted for HDL cholesterol, LDL cholesterol, and LDL particles and triglycerides, it's still inversely associated, although it's not significant. But the hazard ratio is still 0.5.
What's the message of this paper? Is the message that we should abandon measurement of HDL-C and just measure HDL particle number? Would that be more valuable? Is it easy to do? Is it expensive?
We use a commercially available technique, so it is possible to use it at this point. It's not a laboratory technique that needs to be translated to clinical practice. As far as using it, replacing it wholesale, my understanding at this point is that it's still more expensive than a standard HDL cholesterol measure. And I think with a lot of these things, it depends on the question. It really seems like our understanding of the shortcomings of HDL cholesterol really didn't become apparent until we were focusing pharmacologic agents to raise HDL. And that's what really brought it to light this issue that HDL cholesterol may not be the absolute best measure of HDL. As far as risk assessment, at the population level, low HDL cholesterol is still going to be a marker of risk. I think it may depend on how things go with the pharmacologic agents, because clearly HDL cholesterol is failing us there as far as informing what's going on with risk. So it's being dramatically increased, yet we're not seeing the reduction in risk that's expected.
HDL remains still a bit of a complex factor in our patients with coronary disease. We know that it's not good if your HDL is too low. We're not sure exactly how to make it better, but so far just raising HDL-C hasn't worked very well. Your data showing that particle number may be one of the links to new criteria for assessing this. Thanks very much for being with us.
Thank you.